good morning, good afternoon, and good evening. This is Luke from Wisonic Medical in China. And today I'm so glad to meet you. Thank you and welcome all new and old friends to join the new session of Wisonic Dandelion College Global Tour. Wisonic Dandelion College is a free online platform with the aim of sharing the latest knowledge of point-of-care ultrasound applications with experts and doctors around the world, so such as in regional anesthesia, pain management, emergency, critical care, MSK, physical therapy, etc. Okay, so well, today we are so honored to invite Dr. Abiola Fasina as the speaker to share her valuable experience on utility of POCUS, that means point-of-care ultrasound, in clinical decision-making for acute and emergency care in the tropics. And meanwhile, the Dr. Kehinde Ojifinni, as the moderator of the webinar, they are famous experts focusing on emergency and ICU medicine from Nigeria. So welcome to join. Welcome both of you. Okay. So today's webinar will be divided into two.
Thank you.
Okay. The first session will be the speech of Dr. Abiola Fasina, and the second session will be for the Q&A. Okay. So do not hesitate to leave your questions on the Q&A box during the presentation, and we will continue to exchange at the end of the speech. Okay. So now, please allow me to introduce our webinar's moderator, Dr. Kehinde Ojifinni. Okay, so I'd like to share my screen. Okay, can you please see my screen?
Yes.
Can you see my screen, right?
Yes.
Okay, nice. So this is our today's webinar. Okay. And then our moderators, Dr. Kehinde Ojifinni, he is emergency physician and head of Department of Emergency Medicine, University College Hospital in Ibadan, Nigeria. Okay, and Will is also the sixth of the first emergency medicine residency training program in Nigeria. Also, the doctor trained in emergency medicine in the division of emergency medicine of the University which was trained in Johannesburg in South Africa. Okay, also he's also very skilled in the disaster management, education, and ED informatics. So welcome, Dr. Ojifinni. Okay. Okay, so
thank you.
Yes.
Pleasure to be
Dr. Ojifinni. Yes. Okay. So, yeah. And this is your part.
All right, thank you for having me. I want to welcome everyone to this webinar, and to take the main presentation for today is Dr. Abiola Fasina, and I will be introducing her shortly. She'll be talking to us about the utility of point-of-care ultrasound in clinical decision-making for acute and emergency care in the tropics. Dr. Abiola Fasina is an emergency and critical care physician and a healthcare policy consultant based in Lagos, Nigeria. She completed her training in emergency medicine at the Mount Sinai School of Medicine in New York. After several years of practice, she completed a 2-year emergency point-of-care ultrasound fellowship, which we call POCUS, and had a master's in health policy research at the University of Pennsylvania. Dr. Fasina is involved in emergency medicine development and POCUS education in Nigeria, and practices clinical emergency and critical care medicine. He's a board member of the Foundation Fellow of the Faculty of Emergency Medicine at the National Postgraduate Medical College of Nigeria, which was inaugurated in June 2019. She was part of the selected cohort of medical professionals that drafted the National Emergency Medicine Curriculum for future training programs. Dr. Fasina's area of research and interest are focused on capacity building of emergency healthcare systems in low and medium income African countries, specifically around POCUS and clinical decision making. She has worked in several countries, including Nigeria, Liberia, Ghana, Rwanda, Kenya, Tanzania, Uganda, and even in Zanzibar. And she has very extensive international experience. In 2019, after coming back home to Nigeria, emergency healthcare consultant called ECON, a social enterprise focused on medical education and training in emergency and critical care. Up to date, ECON has trained over 250 clinicians locally and in emergency resuscitation, basic emergency care, and of course in POCUS, and opened a dedicated COVID compliant training center in Yaba, Lagos, back in September 2020. ECON has partnered with Fujifilm and Sonosites to launch the West African Sono Expert Academy in order to provide local opportunities to acquire point-of-care ultrasound skills, clinical to improving and optimizing clinical decision-making and medical procedures and making medical procedures safer. Dr. Fasina-Ayoola is also the medical director of Al-Jalad Hospital Systems, Lagos, Nigeria. Al-Jalad is one of the largest private hospital systems in Lagos, with 3 sites across the city. It's a multi-specialist hospital providing a range of services with the aim of providing quality and affordable medical care. Dr. Fasina heads the emergency department of the hospital, which was launched in March 2022. She has recently been funded through a pilot grant from Duke University Global Health Institute to study emergency sepsis with the aim of developing a local relevant algorithm for care. Join me as I invite Dr. Abiola Fasina-Ayoola, the person I describe as an emergency physician with an ultrasonic edge, to deliver a webinar on utility of point-of-care ultrasound in clinical decision-making for acute and emergency care in the tropics.
Okay, welcome. So welcome, Dr. Fasina.
Thank you, Luke. Thank you, Kehinde. Thanks for the opportunity to give this talk. I'm very excited to partner now with the Dandelion College from Wisonic to drive POCUS education. So I'm just going to share my screen. Can you see?
Yes.
Yes, we can see you.
All right, wonderful. So this is just, this talk is meant to give an overview of how we've been using ultrasound in a local Nigerian emergency department. My objectives are to give you that overview of its use in the tropics. It's not specifically limited to tropical medicine, but has really served to help us make decisions faster in a severely resource-limited setting. I'll also be presenting some cases with sonographic images to explain our management. The majority of these images actually came from our Al-Jalad emergency department. I've been working with our medical officers in the department to teach POCUS, and within a year, they've really picked it up, and I've really started to use the modality a lot in clinical decision-making. So let's go right into our first case, which was a positive EFAT. Our hospital is located, our emergency department in our hospital is situated in one of the buildings where we see quite a number of patients. Our ER there sees a number of people every day, and the hospital in total sees about 600 people daily. And we're right by a very busy highway. And so we get quite a bit of trauma because we're at the confluence of several highways coming into that part of Lagos, which, as you all know, is a mega city, the most populous in Africa. So this 22-year-old female was an unrestrained passenger in a public bus, which sustained a collision. And she came into the emergency department. She was brought in by worried bystanders because she presented with severe abdominal pain, and on initial presentation had a systolic blood pressure of 100 and a tachycardia of 109. My medical officer, under my guidance, decided to do a fast. Because of her instability, there was no way to transport her to get a CAT scan. And we just wanted to figure out if there was any intraperitoneal hemorrhage. And as you all know, the FAST is the focused assessment sonographically in trauma. And what it's really looking to do is to investigate whether or not there's any signs of intraperitoneal hemorrhages by looking at 4 places in the abdomen, and also including the lungs as the extended portion, the E of the EFAST, to exclude pneumothorax. So these are some of the images we saw. I like clips, so I'll be presenting clips from my ER today. This was a clip that we got from the right upper quadrant, which is, as I call it, the money shot, irrespective of where the trauma is occurring. Usually a good idea is always to start at the right upper quadrant because of the attachments of the mesentery. That right paracolic gutter is usually where fluid will accumulate first, irrespective of where you're bleeding from. And as you can see here in Morrison's pouch, there is a sliver. This should be a potential space with the liver and the kidney well opposed. And here we have a little bit of fluid in this pouch. So this was exciting to us because it was giving us a sense of what might be going on with this young lady. We went to the left side, and I hope you can see here that on the spleen and kidney side, there is also a sliver of fluid up here, which should not be there. And so we realized that this was a positive FAST. And so with that, we were able to actually call our general surgeons on the basis of the ultrasound. And the lady was taken straight to theater for exploration. So in this case, the ultrasound really assisted us to make a diagnosis quickly, assisted us to help us with our clinical decision tree and get a definitive plan on board, which is not something we'd have been able to do without it because there was no other way to get any kind of imaging of the abdomen of this unstable lady at the time. FAST is one of the modalities we use the most. We have an excessive amount of trauma in Nigeria, particularly in the big cities like Ibadan and Lagos. And we have a lot of road traffic accidents in this part of the world for a variety of reasons. Since we have poorly developed pre-hospital ambulance systems, these patients frequently miss out on the golden hour of trauma. And a lot of them die even when they come to a hospital. So ultrasound has been extremely helpful in helping us to make diagnoses quickly. Many reasons why you can't get CT scans here: financial constraints, the patient's instability, limited availability of CT scan. And so ultrasound at the bedside is extremely useful. I'd like to go to a second case, which was a case in our department of a ruptured ectopic. It was a young lady in severe painful distress. She was afebrile, she wasn't pale, anicteric, acyanosed, not dehydrated. There wasn't any pedal edema of note. Came in with presenting vitals that were just significant for a mild amount of hypertension. But on the exam, we noted rebound tenderness and gardening along the lower abdomen, and she ended up having a positive pregnancy test. I have to say that in Lagos, I do see a big amount of ectopic pregnancy. When I was training in the States, we learned that ectopic pregnancy in women who didn't have assisted reproduction was 0.25% prevalence. And that would go up to maybe 1% in patients who had assisted reproductive techniques like IVF. But in my emergency departments in Lagos, every week, we're seeing at least 1 to 2 ruptured ectopics. So the prevalence is actually really high. There's quite a number of women who end up with this diagnosis in our emergency department. And so these are some of the images we acquired for this woman, which I'll show you here. So here is a longitudinal view in the suprapubic section of her pelvis. And what you can see here, I'll point out the abnormality to you, is that this is our uterus, and here is the vaginal stripe and the cervix at this point. This is the bladder with fluid within it. And right here, we can see some fluid pooling around the uterus. Normally, we would look here. This is the equivalent of the pouch of Douglas. The most dependent part of the pelvis is where you should be seeing fluid. But interestingly, in this woman, we actually saw it here in the superior aspect. Here is another view of this. Here, we had a transverse view this time. So this is our uterus here. And then here, right next to it, we can see a pregnancy. Here, we didn't get any fetal heart rate from this around here. So this is a longitudinal view of the same patient. Moving right along, again, as I said, the right upper quadrant is the money shot, which we did. And again, on this same patient, we see again the same sliver of fluid around that Morrison's pouch, and almost identical to the first case, again, some fluid there. So on the basis of this, we were able to call our ORG consultants, and the lady was taken to theater. So FAST has been extremely useful for us just in our emergency. And this is some amazing images that were acquired with the Wisonic Clover, which I really wanted to highlight here because I've scanned with this machine and it's excellent. It's really good, and also is very good for our environment here in Nigeria, where we have a lot of power issues. We have a lot of variations in our current and in our voltage. It's easy to use. It's a very durable machine. And you can see here that this is an example of an image that we acquired from the right upper quadrant. And it's just very well gained, absolutely beautiful, with the fluid really well delineated on this image. And so these are some images that were acquired with the Wisonic Clover machine. I'd like to go on now to our third case, which is a case of early tamponade. We have a 60-year-old man who came in with hypertension. He had a history of non-compliance with his medical regimen. It's not uncommon here. There's a lot of superstitious and religious thinking amongst our patients. And of course, you don't feel it when your blood pressure is high. So when they feel okay, they stop their medicines or they stop going to see the doctor. And so we have a lot of hypertensive disease in our environment. 1 in 4 Nigerians has hypertension. And in our environment, most of our patients end up coming in with heart failure instead of ischemic heart disease. He'd been lost to follow up over multiple consultations. He'd seen many different specialists, so there was nobody coordinating his care. Came in with severe dyspnea, hypotension, and tachycardia. So we did an echo, a POCUS echo on him. And this is a longitudinal view of his IVC, which I will play again. And you can see that he actually had a full IVC. Here it was leading into the right atrium, and around the heart, we can begin to see a sliver here of a significant pericardial effusion. We got a subxiphoid view of this patient, same one. I'm sorry the clip is so short. And here you can see that he actually has a circumferential pericardial effusion. What are the signs of tamponade on ultrasound? You want to see right atrial compressibility in diastole, or you want to see right ventricular in systole, or you want to see right ventricular compression in diastole. And so what we're seeing here actually are signs of early tamponade here, where you can see already that the right atria is actually beginning to flop around on its free wall on this side. And also here, there was this abnormality along the right ventricular wall. We weren't really sure what it was. Something was flopping around there on that free wall side. Got an additional image here of the right flank. And the man actually also had evidence of some fluid interperitoneal cavity. Here's some fluid around the liver on the right side. Apologies, sorry, around the spleen on the left side. So you can see that here, that there's actually some fluid as well in the intraperitoneal segment. If you look closely here, sorry, the clips are so short. This area here is actually above the diaphragm. And we can also see that there's actually some fluid as well above the diaphragm, indicating the presence of also a pleural effusion. So the man had fluid pretty much everywhere. And so on the basis of that, we called the cardiologist. Pericardiocentesis is actually an emergency procedure, which we're very capable of doing. We've all been trained to do it. And we do it under ultrasonographic guidance. And so we took him up to our HDU and we were able to do that in the HDU. Unfortunately, I didn't get any clips of him after the pericardiocentesis, but we were able to take care of him and he felt much better. The combination of that diaphoresis, diuresis with medications and hypertensive medications really helped the man to get much better and he improved. Next case I'd like to present here is going into, this case was a case of hematuria with flank pain. Was a 46-year-old male. He presented with severe intermittent right flank pain and he had hematuria on his urinalysis. His vitals were significant for fever and tachycardia. And we worked him up and decided that there were a few things we needed to consider, whether or not he had pyelonephritis, or whether he had an obstructing stone, or whether it was just renal colic. We weren't sure. And unfortunately, he didn't have the funds to get a non-contrast abdominal CT. So we decided to scan him to figure out if he had any signs of urethral obstruction on his ultrasound, evidenced by the lack of urethral jets. And so the decision tree was really whether or not we needed to include urology emergently for a urethral stent. And so we got some images of him in the emergency department. Again, I always like to start on that right upper quadrant. You can see, again, a sliver of fluid here. This is the liver, and this is the kidney. We have some shadows here from the ribs, which we weren't able to kind of stare around using this probe. And so we were just trying to just opportunistically get the best image that we could. We also put some color Doppler onto the kidney to assess for hydronephrosis. As you can see, the color box is here on the kidney, and we're looking there to see whether these areas of dilation are actually consistent with dilation within the kidney sinus. And you can see here that we do have some spots here that are not actually vessels, but actually dilated areas of the sinus, indicating some hydronephrosis. Now, hydronephrosis is graded qualitatively just using your eyes, and you can go mild, moderate, or severe with the bear claw, where classically it looks like the claw of a bear, and the entire center of the renal sinus is dilated with urine that's backed up. In this case, that's not what we are seeing. What we are seeing here is just a mild amount of hydronephrosis in that renal sinus on the right side. We took more images of this man, and of course, here again is a better view of that right kidney, showing here. Of course, you always have to kind of look in every quadrant. I teach officers that there are 4 places they need to clear when they're doing fast. They need to clear above the diaphragm, right below the diaphragm, above the liver or the spleen. Then they have to clear splenorenal or Morrison's pouch, and then the inferior pole of the kidneys as well. Those are the 4 areas where fluid is likely to coalesce. And so when you look there and you do it systematically, we can see that actually there's some fluid coming into view right here as well. And so he had a positive fast. Here again is another area on the left side now where we're looking for hydronephrosis. And we can see the areas where there's vessels lighting up, and then concomitantly areas that are not giving us any signal on color, indicating that there's a little bit of hydronephrosis as well. So this man had bilateral mild hydronephrosis. So that was already one concerning sign. Then we ended up going to the suprapubic view to look at the bladder. And here we have a nicely defined bladder here, usually a bit rectangular in shape. And when you look here on this side, we put the color Doppler on and tried to see if we could get any jets. And we were able to get the left urethral jet alone on this patient. We could not attain a right urethral jet, which suggested that perhaps there was some obstruction on the right side on the ureter. So on the basis of these ultrasounds, we were able to get our urologist involved for a consultation to determine if the patient would require a urethral stent. Because of course, if you don't divert that infected urine behind the stone, it doesn't matter how much antibiotics you give, there's no chance of improvement. In addition to that, of course, he received the usual therapy of analgesia, antibiotics, tamsulosin, and alpha-1 adrenergic medication to help with movement of the stone, and neurology followed him quite closely until symptom resolution. These are cases that I'm presenting that really had a very nice sort of story. We do have a lot of them, obviously, that don't do well or end up not surviving, even after we find the abnormality, unfortunately, in this environment. And such an example is this patient I'm going to present, who ended up being a code blue or a cardiac arrest. Was a CCU patient that was admitted, was planning to get a valve replacement the next day. And I was called from the ICU to assist them because the patient went into cardiac arrest and coded, and they called for the critical care or emergency doctor to assist. Unfortunately, this patient eventually died. In the middle of the code, I got one view in the parasternal lung axis of the patient's heart. And I've just never seen anything like this before. This mass sitting just overlying the ventricle and the aortic outflow tract, just hanging there, obstructing everything. Also, we can see that this patient had a pericardial effusion as well around the heart. So this was really remarkable to me. Unfortunately, the patient subsequently died. If we look here at the left ventricle, you can see that there's tachycardia, and that ventricle is not really filling. There isn't any volume there to really push out. This is the mitral valve with the anterior leaflet of the mitral valve already hitting the intraventricular septum here. But this is the actual cavity or chamber of the LV, and there's absolutely no volume there. So whatever this thing is, not only was the LV not filling, but there was no chance for any blood that was in there to actually come out as well. So it's a pretty remarkable ultrasound. And unfortunately, we were not able to get this patient back. He ended up arresting, and we ended up having to call it, and he died during this code. So what else have we been using it for? I've been showing you a lot of abdominal scans, and I've showed you an echo. We've actually used it a lot for other things as well, more minor complaints. We had a middle-aged man who came in with cellulitis along the medial malleolus of his right lower extremity. He'd been having persistent pain. He'd already been put on antibiotics in our hospital and was telling us that he didn't feel his symptoms were improving. On the examination, the repeat exam, we saw some evidence of induration. There was a little bit of fluctuance. And there was a question of whether or not this was actually an abscess that needed to be drained. And so, of course, we ended up going in to have a look at that. And we ended up doing a water bath. I really love water baths because I find that they are extremely useful for seeing extremities, which don't have a lot of subcutaneous fat and are very, there's not a lot of fluid in those areas when they accumulate. And so trying to do an ultrasound directly is difficult. And so essentially it's exactly what it sounds like. You get a basin of water. Remember that ultrasound is optimized for liquid media. You don't have to use gel when you're doing a water bath, and you simply put in whatever it is you wish to scan, fingers, toes, feet, whatever that is, and you scan by putting the probe, you hover over the water. You don't have to come directly to the surface of the skin, and you use the water as the transmission medium to see what you need to see. So here we are, this is all the water in the bath, and we are scanning along his medial malleolus at this time. And you can see here the evidence of his cellulitis, this cobblestoning pattern that you're seeing. This is his skin right here. The probe was hovering somewhere around here. And here you can see small pockets of fluid within the tissue along his lower extremity here, indicating that he did have a small collection of fluid. This was in the longitudinal. I then did the same thing. I'm sorry, it's mislabeled right upper quadrant. We then did it in transverse to try to get another angle on this. And you're seeing as we scan through a bit of fluid accumulating here. When I looked at this, obviously, I didn't think that this was a very large abscess. We ended up not actually draining it. We decided to stay the course on our antibiotics because the pocket we saw was quite small. But I have had somewhere the pocket is really large, and it's really clear that you have an abscess you need to drain. You see the positive swirl sign, posterior acoustic enhancement, and all the signs that you would normally see with an abscess, which indicates that you really need to incise and drain it. The patient came in 2 days later for a wound check, and we just continued to reevaluate his course to check up on him and make sure that he would improve. Any questions so far as I continue? I'm seeing some, or maybe we take the questions at the end, just so that we can get through the presentation, Luke. Okay, all right. So moving on with some of the cases that we are presenting, I have 3 more. We have a young male here who presented, he was in septic shock. He had a white count of over 21, lactate of over 4. He was hypotensive. He was already confused and becoming oliguric. We had to start him on pressors after putting in a central line. We started him on norepinephrine, and eventually was taken to the operating room on the basis of our ultrasound. Spent 3 weeks in the operating room and actually in the ICU, and actually survived. So this is his ultrasound. We got still shots of this. This is actually the right upper quadrant, and this is his gallbladder. So it's interesting because I never actually saw a stone, but you can see here that he has a thickened gallbladder wall. There's trace pericholecystic edema of fluid around this gallbladder. This is transverse and longitudinal. And on the exam, he also had a pretty remarkable sonographic Murphy sign. So some of the things that we look for with cholecystitis for ultrasound, we look for a thickened gallbladder wall, which should ideally be thicker than 3 millimeters. We look for pericholecystic fluid. We look for a gallstone with acoustic shadow. And usually you see the shadow before the stones, actually. The shadow is what clues you in that there is a stone. And then lastly, on the exam, you look for a sonographic Murphy sign. Basically, when you push with the ultrasound probe over the gallbladder, the patient will report pain. And so those are the 4 signs that we are looking for when we are trying to assess for gallstones using POCUS. So eventually he went to theater. This is the surgical specimen that we took out. He was really ill. As I told you already, he was in septic shock, ended up in ICU for almost 3 days, had a lot of pressors. I think eventually we ended up having to add epinephrine and norepinephrine as well. And his CVPs continued to remain below 60 for a while before they eventually rose up. He needed to have 1 course of dialysis actually because he went into acute renal failure. So he ended up being really sick, and he's a very lucky man to have survived the course. And the entire diagnosis was made on the basis of the ultrasound. Case 8, we had a female in her 40s who presented with epigastric tenderness, nausea, and intermittent abdominal pain. Her pregnancy test was negative. And so again, we went in with our ultrasound because that was really all we had in the department to try to help us guide our care regarding what it is we could do for this woman to assist her to make a clinical decision. And so we got some right upper quadrant views of the gallbladder. And here you can see, I'm using a curvilinear probe here. I've placed it on the right side. The way I learned the gallbladder scanning is that you really want to try to take your probe, and the gallbladder lays in a fossa within the liver, can go anywhere from the subxiphoid all the way to the anterior axillary line. And so you take that gallbladder, the probe, and you kind of run it along the right costal margin, angling upward under the liver. And eventually, as you're going down that line, the gallbladder will pop into view. Sometimes that's not possible. You have to rotate the patients to have them actually put their right side up. You tell them to rotate a little bit to the left, and so that the right side comes up. Sometimes that makes the gallbladder fall out of the fossa so that you can see it a bit easier. Another trick you can use is to ask the patient to take a deep breath if they're able, pushes the liver down, pushes the gallbladder down, brings it out from the costal margin so that you can see it. Last trick I use sometimes is I switch to a cardiac probe, put it on the abdominal settings, and I go in the intercostal areas and try to angle to see the gallbladder from the superior aspect instead of the inferior aspect if I'm really having trouble seeing the gallbladder. So here we were able to get it. This is the view of the gallbladder. You can see that you're only seeing the anterior wall because there's this large stone there with a nice acoustic shadow completely obscuring the posterior wall of the gallbladder. Here, I didn't really think the wall was thickened. You always want to take the measurements on the anterior wall here, the part abutting the liver. If you take it from the bottom, sometimes there's posterior acoustic enhancement, which might actually obscure your measurement. We got another view of it here. Again, here is this gallbladder in the longitudinal with a large stone within it and a big shadow. So it was looking like this woman might have some biliary colic. Again, taking more pictures of this because you want to take as many pictures as possible. Remember, ultrasound is a 2D modality trying to scan a 3D object. So the more pictures of this you can take, the better for you. We took more pictures here in the longitudinal and actually realized that it was multiple stones within the gallbladder. And then the last picture of this is our wall measurement here, where we measured it out at 2.8 millimeters. So the wall wasn't thickened, didn't have any evidence of fluid around the gallbladder. And the lady at the time was not actively having pain, so I didn't elicit a sonographic Murphy's either. So it looked like it was cholelithiasis, not cholecystitis. And so with this lady, we focused on analgesia and we booked her for surgical clinic follow-up to discuss an elective cholecystectomy with the general surgeon. And the remainder of her workup was negative. This is going to be my last case that we're discussing today. As I mentioned earlier, 1 in 4 Nigerians have hypertension. We have frequent presentations of heart failure, ischemic heart disease is not as common as in Western countries, but we have quite a bit of heart failure, combination of tuberculosis and hypertension. So we had a patient who presented the usual story, dyspnea, hypotension, non-compliant with their BP drugs, came in and we wanted to do an echo to assess what's going on with their heart. So here you can see a longitudinal view of the inferior vena cava. We were trying to assess the volume status. Here you have to be very careful when you're taking this. I usually try it in the transverse and the longitudinal. You always want to get the longitudinal view because you want to trace that IVC actually going into the right atrium. Without that, you might be fooled. The aorta is also around this area. And if you don't confirm it on the longitudinal, you will mistake the aorta for the IVC. There's a parasternal short axis view of the same patient. In this case, you get on the apical beat or the point of maximal intensity. You angle your probe depending on the modality and where your probe marker is towards either the right hip, towards the left hip or the right shoulder. Towards the left shoulder or right hip. And this way you get this view of the heart in the short axis. You want to cut it through the mitral valve. This is the classic fish mouth that you're supposed to get. And here we're seeing a cross-sectional view of the left ventricle with the mitral valve right here. And this is an excellent view. The parasternal short axis view is an excellent view for taking wall measurements, especially for LVH. It's a very excellent view for assessing the EF, which you can just do quantitatively. All of our studies are showing that the eyes are just as good as all of the measurements that you take. And so taking a look at the heart through a cardiac cycle and just seeing how much squeeze occurs through each cardiac cycle is actually a very accurate way of assessing the ejection fraction. And as we looked here, we can see that this heart seems to be squeezing well, but we also noticed that the heart didn't seem to be feeling particularly well as well. So even though it was squeezing properly, the volume that it's squeezing out was not that great. So that was just a visual assessment of the EF from this study. Then we took further views. This is the same patient with the parasternal long axis view. This is my favorite view. It has so much information. If you're looking at this view here, this is the right ventricle, and this is the left ventricle with the mitral valve, the anterior and posterior leaflet. This is the descending aorta and the left atrium. What we can see here actually is that one, there's something we call an endpoint septal separation, which we do in M mode. Didn't really do it on this patient, but a corollary or a surrogate to that is to just look at how close this anterior mitral valve leaflet comes to the intraventricular septum. The closer it comes to the septum, the more compliant the heart, the better the EF. So the first thing we can see here is that this mitral valve leaflet is barely touching this thing, indicating that maybe the EF is not so great. Also, if you look at the left ventricular chamber here, what we alluded to on that parasternal short axis view, can see that the heart doesn't seem to be squeezing very much, a very indolent sort of beat. It's kind of taking its time. So there was a concern here that there was a moderate diminution of his EF. Another reason why I love this view is because this aorta is a landmark. If you see fluid sweeping above it, that's a pericardial effusion. If you see fluid sweeping around it, those are pleural effusions. And you can see from this view that there's quite a bit of black around this aorta, indicating that this patient actually also had a pleural effusion. Lastly, we tried to get an apical 4-chamber view. We really couldn't get it right on axis. And it's actually a bit of an apical 5-chamber. We're beginning to get into the apical 5-chamber. But here you can see this view, extremely informative, especially if you're worried about massive PE. You can use this view to access from a corner sign. You can use this view to look at the proportion of the right ventricle to the left ventricle. The right ventricle to left ventricular ratio should be, the right ventricle should be 1/3 of the size of the left ventricle. If that inverts, you need to start getting worried about increased right-sided pressures. So here's our left atria with our left ventricle and our right atria with our right ventricle. And basically here, we're just looking to see about the proportions of those chambers to each other. Here is an excellent view where you can now start to do your diastolic measurements if you're skilled in diastology. Once you get an apical 5-chamber view, you can start to do pulmonary arterial systolic pressure measurements and other things. This view is also excellent if you want to look at regurgitation, because you can just turn your color mode on, put it behind the valve here, and look at the regurgitant flow jet and the strength of it to see whether there's any regurgitation from any of the valves. So looking through here, we decided that even though we didn't get the best view because it wasn't directly up and down, that the right ventricle looked roughly what it should be relative to the left ventricle, meaning that it wasn't larger than it. And so we weren't also concerned about pulmonary hypertension or pulmonary embolus in this patient. So again, it revealed a right pleural effusion. We had a trace pericardial effusion, which I didn't mention, which we also saw on this view as well. Just a very small one. You're beginning to see slivers of it here, some of it there. Definitely didn't need any kind of pericardiocentesis, a poor EF, and also a dilated LA. Let me take you back to this image. What I learned in my fellowship was that when you're looking at the parasternal long axis view, the right ventricle, this aortic outflow tract, which is obscured here by a rib, and an LA, the left atria, to be about the same size, 1/3, 1/3, 1/3 of the screen. When you start to see one of them dilating or getting bigger relative to the other, it represents changes to the size. And so here we're seeing that this LA is actually beginning to be bigger than this aortic outflow tract and our RV, which was a bit obscured on this view. If you look here on the apical 4-chamber view, you can see the same thing, that the LA actually looks a little large. The reason for that and why it's important is because dilated LA usually is your first sign that you really need to start thinking about diastolic dysfunction as well, and doing some dedicated diastolic measurements to see if there's also diastolic dysfunction in addition to systolic dysfunction as a cause of maybe the heart failure. So I'm going to pause here from my presentation and let Luke take us through some of the Wisonic solutions before we take questions from the audience.
Well, thank you so much, Dr. Abiola Fasina, for your wonderful presentation. And thank you for giving me this opportunity to take over this introduction for the Wisonic point of care ultrasound. Yes, actually, as everyone knows, Wisonic is the innovator of new ultrasound. Okay, for the application, for every point of care ultrasound application field, we can provide the most professional and dedicated solutions. Okay, so this is, as you can see, this page is our product lines. For every point of care application, we have the dedicated solutions. For example, for critical care, Dr. Fasina, can you please move to the next page? Yeah, thank you. Yeah, okay, so this is the latest generation of ICU ultrasound designed for critical care. Okay, the ultrasound. Okay, and then next page, please. Yeah, and then as you can see, this is our point of care portable ultrasound, the Clover and the Clivia. Okay, and with excellent image quality and the performance designed for the point of care applications, including the designs, including the software options. So especially to help the clinical doctors to learning the point of care ultrasound skills. more easily and to help them improve the skills in this field. Okay, so thank you. So yeah, this is the training. Yeah, Dr. Fasina.
Yes, so just some pictures from the Lagos University Teaching Hospital. We were able to facilitate some training for their critical care staff using the Clover, which was generously provided by Wisonic. And we were able to take them through the basics of ultrasound, a bit of ultrasound physics, and also how to get some basic cardiac views and fast. And so in summary for my discussion, POCUS has been excellent in resource-limited settings. Of course, I train in POCUS, so I love it, but I've been a champion of it in our environment for so long because it's between POCUS and X-ray. I think you will be, between ultrasound and X-ray, 60% of your imaging needs in a resource-limited setting will be met. That was from a WHO brief that came out several years ago. It's been extremely useful in our environment. It's alleviating problems we're experiencing with a lack of access to imaging easily. It's improving our clinical decision-making and our clinical diagnostic certainty by allowing us to definitively make a decision or eliminate things that are not of concern. Nigerian doctors are getting introduced to a new skill set, which is really at the forefront of clinical care now. Most specialties outside of psychiatry are beginning to include point-of-care ultrasound in their residency trainings. And so it's important that we bring our Nigerian doctors up to speed. And then there's so many modalities that we are using, even outside of the ones that we have showed you here, that have been extremely helpful for us as we try to make decisions and care for our patients in our hospital. And so without further ado, I want to thank Wisonic, the Medical Division of Ultrasound, and Dandelion College for sponsoring this talk and giving me an opportunity to speak about my experience. I want to thank Jalad, I'm the medical director there, who supported the development of an emergency department and purchased a beautiful machine for me so that I could take all these images. And I want to thank Econ for serving as a POCUS, as a center for point-of-care ultrasound education training in Nigeria. At this point, we'll take any questions that people may have about what we've discussed.
Yeah.
All right, thank you so much, Dr. Fasina, for that wonderful presentation. And also thank you, Luke, for giving that perspective from the Wisonic as well. I know that our audience have a lot of questions. I have some of them here. And Dr. Fasina, please get ready to take them one after the other. I will start with a question from Dr. Yannick Ndefo. Dr. Yannick Ndefo is from Cameroon and is the POCUS ambassador for Cameroon. So he's saying that I'm trying to expand POCUS in my community by sharing case reports during congresses and on social networks. Thank you for doing that. So the first question he has is, what is the best approach to establish a POCUS curriculum in a hospital? And how do you manage to spread it? That's his first question. What is the best approach to establish a POCUS curriculum in a hospital? And how do you manage to spread it? I want to take all these questions together so that Dr. Fasina can answer them at once. He's asking also that, please, in your hospital, what is your experience with POCUS in hemodynamic management? Your experience with POCUS in hemodynamic management using VTI, which is, I think that's a aortic velocity time integral. Using VTI, using mitral Doppler, and other measurements. That's the second question. And the last question from Dr. Yannick Ndefo is, how do I build a partnership with ultrasound machine manufacturers to support POCUS curriculum? I think maybe that may be answered by Luke, or maybe Dr. Fasina as well. Before I take other questions, we can answer these ones from our doctor from Cameroon. Thank you.
Wonderful, thank you. So in order to spread the mantra of POCUS, I found that you need to get buy-in from the traditional stakeholders. You can't allow them to pause your progress, but it's important that they see you as a valid imaging resource that is not there to supplant them. By that, I mean your radiologists, your sonographers. You need to do a lot of diplomatic politicking with them to help them understand what you're bringing to the table with point of care ultrasound, and to help them understand that it's a point of care test that is not going to supplant definitive imaging from the radiology department. Humans are economic animals. And so one of the first places where people usually encounter resistance is from the traditional imaging department. So you have to do a bit of footwork to reassure them that you're working in tandem with them. And I always explain to them that actually, whenever I can't make a definitive diagnosis by POCUS, guess what? I'm still sending my patient to you for technician-driven ultrasound or for CT scan. So what we're trying to do is just narrow our diagnosis so our questions are more targeted. As you're trying to also expand it as a program in your centers, the truth of the matter is that if there are no machines and there are no teachers, then it's going to be difficult to do. So first, you need to do a needs assessment and figure out where your machines are and who are the people that are going to be skilled enough to teach people how to use POCUS. If you are in a hospital that's anything like what most African hospitals are, there are ultrasound machines everywhere, and some of them may be very old and some of them are fairly new. Doctors usually have one or two mobile ones that they have maybe purchased on their own. So one of the things I like to do in the beginning is take an inventory of the machines. Where are the machines? So that whenever we want to do a point of care ultrasound, particularly at the odd hours, on the weekends and at night, where would we have a machine that our staff in the emergency or in the critical care areas of the hospital could go to get a machine to use? And then who's going to teach it? Because once you start to do it, you need to have a quality improvement process. Who is going to be downloading the images, reviewing the images, and providing feedback to the trainees about what they're seeing? So at the minimum, those three things are the steps you need to take to establish and try to develop an ultrasound program in your facility. Now, when it comes to the issue of VTI and other more advanced measurements in critical care ultrasound, certainly they are very much of use. And if you can do them, you should do them. I have to say that for most of our patients in our emergency department, I can do all of the diastolic measurements and the VTI. But most of the time, I get my answer just from the basic 4 views, the parasternal long axis view, the apical 4-chamber view. And when I start to do all of the extra things, it's really because I'm beginning to hunt for very specific information. Those things are very useful in critical care ultrasound and in your resuscitations. But I would advise you that as you're teaching your trainees who may not be as skilled, focus on letting them learn how to get very good images first, before you layer on some of the more complex measurements using Doppler, power Doppler, color Doppler, and all of those things. I hope that's answered your question. Look, I think they had a question about how to liaise with device manufacturers.
Yeah.
So Luke, the question is, how do I build a partnership with ultrasound machine manufacturers to support POCUS curriculum? Luke?
Yes, could you repeat again, please?
Yeah, so the Dr. Ndefo wants to know that how will he build a partnership with ultrasound machine manufacturers to support the POCUS curriculum in Cameroon, for instance?
Yeah, normally we are working with local partners because we have no local offices over there, but first of all, we build the cooperation with local partners, and then we have the machine. So this is first step, and then we will looking for the opportunities on the cooperation with the local doctors like Dr. Yannick. So to spread the point of care ultrasound skills with the local associations. We cooperate with local KOLs and the local associations to promote the point of care ultrasound skills and to help the local doctors learning together like this.
All right, thank you very much, Luke. I think it would be useful for Dr. Yannick to get in touch with Luke through the website for Wisonic to be able to know how to go about this for Cameroon. Thank you very much.
Yeah.
Emeka Momar wants to know, what body part is that you were showing with the water bath, Dr. Fasina?
Yes, so that was actually the medial malleolus, so it was the distal tibia. And so with the water bath, you just want to make sure the container that you're using is large enough to contain whatever you need to scan. So I got a very wide and tall bucket. I filled it with water and I submerged the foot in the bath. The good thing about the water bath is you don't have to bring the probe directly onto the skin. You can just hover on the surface of the water and direct it towards the object of interest. And the water will serve as the conductor of the ultrasonographic wave. So it was actually the foot, but I've used the water. I find the water bath is the most useful for extremities. So I tend to use the water bath a lot when I'm scanning fingers, hands, feet, toes, because those areas are so small and they don't have a lot of subcutaneous tissue, and trying to scan them directly is difficult. So using the water bath ends up making it much easier for me.
Thank you very much, Dr. Fasina. I mean, that brings us to understanding POCUS with respect to musculoskeletal system as one of the modalities for POCUS. There are some questions here that I want you to answer them one after the other. Someone says, where can POCUS skills be acquired locally in Nigeria and the region?
Excellent. So POCUS skills can be acquired at emergency healthcare consultants. We've partnered with Wisonic and other device manufacturers and run a POCUS academy. We run periodic trainings on different modalities, and you can just go onto our website. I'll put it in the chat. Contact us, and if we have a quorum, a big enough class, we run classes in POCUS. We have done them in cardiac echo, in critical ultrasound, in abdominal ultrasound. We're partnering with Wisonic to actually deploy an obstetric ultrasound training soon for novice scanners and midwives. We've done it. We have eye, musculoskeletal, all kinds of modalities available. Other places where you can acquire trainings locally is in places where emergency medicine residencies occur. So for instance, if you happen to be in Ibadan and you're an officer or a resident at UCH, Dr. Kehinde and Dr. Aciola are there and are very skilled in ultrasound and can also take you through the basics and get your skills up to speed.
Thank you. What other modalities are there that maybe you didn't show us in the course of the presentation?
Fantastic. So we use it a lot for the vascular stuff, specifically the DVT and two-point compression. We use it a lot for the eye. Most people don't know that ultrasound can be used for the eye using the linear probe. So we use it to diagnose retinal detachment, intraorbital hemorrhage, check the optic nerve sheath diameter as a surrogate for intracranial pressure that's elevated, look for fractures around the eye. So we use it for the orbits, kind of a lot of ultrasound around the musculoskeletal area. So you can use it to diagnose the shoulder dislocations, do your nerve block or your regional anesthesia, and then also use it to check to see if your reduction is good. So sometimes if I don't have X-ray, I just use the ultrasound for my shoulder reductions. Of course, there's a lot of applications in pregnancy that we didn't even cover that you might do. Most of the ultrasound in the emergency department tries to stop after the 20th week of pregnancy and then send patients off to O&G. But certainly some emergency doctors really do get very good at obstetric ultrasound and really go all the way to third trimester scanning. So there is that. I use it a lot for procedures. So my ultrasound for central line placement, I use it for peripheral guided IVs if the lines are difficult to get. So I use them for line placement, use them for lumbar punctures when we can't get landmarks properly to kind of put things in, put the needle in. I use it for paracentesis so that I don't pierce the gut. So in anything where I'm actually putting a needle into the patient, for the most part, I try to do it with ultrasound guidance. So there's a lot of areas. There's a whole area of lung ultrasound that I didn't even discuss here to diagnose pneumonias, pneumothorax, fluid, pleural effusions, pulmonary edema. So those are some of the modalities we use in ultrasound and that I've used in the department periodically that I didn't really explain or explore on this talk. So anywhere you can get the probe on and navigate around the bones, you can scan it.
Thank you so much. That makes it so interesting. everybody will be interested in getting a bit of point of care ultrasound with what you've said so far. And I must say that ultrasound is becoming the new stethoscope, I can take care of so many things that you can do right by the bedside. Thank you very much, Dr. Fasina. There is one more thing that I want to ask. Someone is saying, how can POCUS be made economically viable for hospital systems? And another one is asking, how many scans are required to attain proficiency?
Okay, so this question of viability of the modality is critical for survival and also speaks to some of Dr. Yannick's concerns around how to get buy-in. One of the biggest ways you get buy-in for this modality is if you can show your hospital directors and management that it's making money for the system and that it's making patients happier and helping to decrease complications and adverse events. In Nigeria, I'm still in the process. I have to say I'm struggling. A lot of our patients who are on HMO and insurance plans, our HMOs still don't really understand what to do about an ultrasound that is not done by a cardiologist or a radiographer. And so when we do the POCUS studies in the emergency department, it's usually fine. But if we then have to go and get a confirmatory study because the study is not conclusive, we run into problems with them kind of coming back to us saying that we're doing duplicate studies. Why are we doing 2 echoes, or why are we doing two abdominal ultrasounds, and sort of have to kind of talk through that and explain to them what it is POCUS is and why it's different from traditional technician-driven ultrasound. So I think one of the things that you have to do to make this viable is to really engage the hospital management. When we don't have our insured patients in hospital, it's much easier. We typically just bill for the ultrasound and we just bill it at a lower price point than a confirmatory study because it is a bedside test. So we do ask patients to pay for the study as a way to keep it sustainable and viable, because we have to make sure we are continuing to provide all the equipment needed to sustain the modality. For your insured patients, it really involves a lot of engagement with the clinical team, to the clinical team on the insurance side, to explain to them what this new modality is and how it's of value to their patients. And that's vital for you to do so that the modality survives and is incorporated into clinical care wherever you're working.
Thank you very much, Dr. Fasina. Someone wants to know concerning the using the water bath. Does the probe has to be in contact with the water?
Yes, the probe has to be in contact with the water. Remember that ultrasound is optimized for liquid media. So the probe needs to be either on the surface of the water, angled towards the object of interest, or you can submerge it in the water without getting the tubing and the wiring wet. It doesn't have to touch the skin, but it needs to be in contact with the water in some way to actually take the image for you.
Thank you. Questions from Martha Uwachiku and Olufunmilayo Olokodano Adesalu are quite similar. So Olufunmilayo is asking, saying that it's a very lovely lecture that you deliver. Thank you. And very inspiring. And she's asking, how can medical practitioners who may be interested as well? And the same for, so it's a question about how can medical practitioners who may be interested in improving their knowledge benefit. Is there a training? Is there a place where they can attend trainings?
Yes, we kind of mentioned that earlier. You can contact us at Econ. I've put the website in the chat box. You can also mosey on down to UCH in Ibadan, where there's an emergency medicine training with trained specialist emergency doctors. And they have a lovely ultrasound machine as well. And so if you happen to be an officer, a doctor in that respect, you can go there and learn. If you're not at UCH, in Lagos, we have our Econ Training Center, and we have an academy for POCUS training, which you can also get in touch with us to learn and to get some training. And we are in partnership with Wisonic, so they are also helping us with some of our trainings. And so you can just check the chat box for the link to the website.
Thank you. Alexandra wants to know, how many scans do you require to attain proficiency?
This has been something that POCUS educators are debating up and down. So many numbers have been postulated. I don't know that anyone actually really has a good idea, but I would say that at least you should be getting 50 per modality. So if you want to get good at echo, when you're in the training period, you should try to get at least 50 scans. And the way I recommend people do this is that whenever you're working, you should try to scan everybody that's going to have a confirmatory study. So when I was learning POCUS and I had my scanning shift, if somebody was getting a CT abdomen pelvis, I would go and scan that person. Now that they have a CT abdomen pelvis, I would scan their kidney, I would scan their gallbladder, I would scan their liver, I would scan their aorta, I would scan their suprapubic space. I would do it fast because now you have a confirmatory study that you can compare to see if your interpretation of your scan is accurate. Because you don't only have to learn the mechanical skills of scanning, you also have to learn how to look at it and interpret what you're seeing and decide what is normal. If somebody was having a cardiology formal echo, I'd go to that person and do a bedside echo so that I could compare it to the cardiology echo and see the comparison between the images and the interpretation I'm getting and the images and interpretation that the cardiologist is getting. If somebody was getting a CT of the head, I would scan their eyes. If somebody was getting a CT of the chest, I'd go and do an echo and a lung ultrasound. I'd do a thoracic aortic study. So that's a way where if you have limited access to teachers, you can teach yourself how to interpret your studies by comparing to the definitive study. I also want to highlight the Global Ultrasound Institute, GOSI. It's another resource I'll put on the chat box. I'm an instructor for them. Their goal is to get POCUS worldwide. They have a whole academy available. And one of the things they do in that academy is that there is the resource for you to kind of sign up for remote image review, where the GOSI faculty can actually, from wherever we are in the world, look at your images, give you feedback, and help you through learning your ultrasound a bit better.
Thank you so much, Dr. Fasina. So I just want to say that in clinical decision-making, ultrasound has come a long way, especially point-of-care ultrasound. We shouldn't be afraid to get involved with it. And of course, in our various different parts of Africa and in the tropics generally, we know that we still have to give a lot of respect to the traditional scanners. And that's our radiologists, like Dr. Fasina has said. And as they begin to see the need for us to do more ultrasound, especially in the emergency department and as a form of point of care, bedside ultrasound, they would allow us to do more. And then we can leave the more advanced stuff to them so that we can take decisions quickly with ultrasound. Ultrasound is fast becoming the new stethoscope, like you said, and we will enjoy you to partner with us and partner with Wisonic as well. Thank you very much for answering all the questions. And thank you, Luke, for the time.
Thank you all.
Yeah. So is anyone else has questions? Yeah. Does anyone has questions? Yeah. So Dr. Fasina, you just sent the link, right?
Yes, I sent the link for local training, and I also sent the link for the Global Ultrasound Institute.
I see. So let me transfer to all of the audience so everybody can see. Yeah. So this is the training organizations, so the local, right?
Yes. And this is the link to the Global Ultrasound Institute, if you can send it to everyone as well, so that they can see, they can actually go on there and they have educational material, they have remote image review. So if you're trying to build a program and you don't have enough instructors and you really need faculty to help you teach POCUS, Dr. Yannick, Global Ultrasound Institute is a great resource because they're finding ways to help people get POCUS programs going all over the world.
Dr. Fasina, can you also send the link for Econ? Someone is asking.
Yes, I've posted that. It's on the link.
Website.
Yes, it's there, www.emergencycareconsultant.com. Luke has posted it to the chat, so just look there and you'll see that as well.
Yeah.
Thank you.
Okay. Does anybody have any else questions? So,
oh, I forgot to mention, if you're in Lagos, stop by the Arjolad Emergency Department. We're also happy to take you through.
yes.
And of course, the same thing goes for Ibadan. If you're in Ibadan, just come to USAGE Emergency Department. Ask for Dr. Akinola or Dr. Ojifinni. Yes, we'll be glad to share our experience with you as well. Thank you.
Okay. So, okay, thank you so much. Okay. Finally, let's thank again the wonderful presentation from Dr. Abiola Fasina, and thanks for the good job from our moderator, Dr. Kehinde Ojifinni. Also, thank you for everyone, all the audience, for staying with us during the webinar. So for more information about the new upcoming webinars or the record of previous webinars, so please feel free to follow Wisonic official channels on Facebook, LinkedIn, and YouTube. Okay, thank you, everyone. So let's see you next time. Okay, thank you, everyone.
Thank you.
Thank you. Thank you.
Thank you. Bye.
Thank you. Bye bye. See you next time. Okay. Everybody. Oh, anybody has put up? No. Let's see. Any more questions? No. Okay. Okay. Thank you. Thank you. See you next time. Bye bye.